Good afternoon and welcome to this webinar hosted by ICIP and ICIP South Africa. And we have the pleasure of introducing our guest speaker today, Dr. Goodman Sibeko. Dr. Sibeko serves as Head of Addiction Psychiatry at the University of Cape Town. His work is focused on interventions using non-specialist workers in the management of severe mental illness, and has a developing research portfolio focused on task-sharing models for the treatment of harmful substance use, mental health, and HIV. Dr. Sibeko also serves as co-director of the South African HIV Addiction Technology Transfer Centre. On top of all of this, Dr. Sibeko also sits on the steering committee of ICIP South Africa and has been an integral part of the planning committee that has brought the first virtual African conference on drug demand reduction to life. He will also be moderating some of the sessions of the conference, including plenary 5, the role of legislators and traditional health practitioners in drug demand reduction, on November the 4th, 2020 at 2 p.m. Dr. Sibeko, thank you so much for giving your time today and allowing ICIP to host this webinar entitled the South African HIV Technology Transfer Centre, Journey, Impact and Lessons. And I'll hand over to you now.
Thank you, Roger. It's a pleasure to be introduced by you. And thank you to ICIP for hosting me today. I want to extend a special welcome to the representatives from the South African national and provincial governments, as well as to the South African HIV ATTC's advisory board. Also welcome and thanks for joining us to the TTC network and the National Coordinating Office, Laurie Croman team. Also want to thank and welcome ICIP from around the globe, global and the national chapters across Africa, the US Department of State, and by no means least, the University of Cape Town's Department of Psychiatry and Mental Health. What I'm going to seek to do today is to locate the ATTC, talk about how do we fit in the greater scheme of things, and then just to look at some of our processes and look at what we've done over the past 3 years of funding and what we've achieved, what we would have liked to do better, and then talk about what will follow as our funding comes to an end. So the ATTC, South Africa HIV ATTC, really forms part of an international network. The purpose of the international network is to add value to PEPFAR's HIV prevention, care, and treatment programs, to the provision of technical assistance, mentoring, and training around substance use disorders and other behavioral drivers, including mental health. You'll note in the image that there are sort of a few US domestic ATTCs which don't fall under the PEPFAR banner, whereas the international portfolio falls under ATTC. So I guess here a special shout out to our friends in Vietnam, Southeast Asia, and Ukraine, who are hopefully watching. So the purpose really of the ATTC network is to accelerate the diffusion of innovations which are evidence-based for substance use, mental health, and particularly in the context of HIV. And this is achieved by making use of various an array of technology transfer strategies. What I'll be talking about later is how some of our interventions in South Africa have been sourced or developed, and then talk about how the translation of that has taken place. And then, along that spectrum of dissemination to implementation. Ultimately, the systems within which we work, it falls to them to then figure out how do our interventions then become implemented. We either don't step back and say, you do that. We are also then part and parcel of that discussion around implementation of these best practice interventions. Specifically about the South Africa HIV Addiction Technology Transfer Centre, it's a lot of English words, so it's easier to say ATTC. We are funded, as I've alluded now, by PEPFAR through SAHMSA, the Substance Abuse and Mental Health Services Administration in the United States. And you represent a partnership between the New England Addiction Technology Transfer Centre, which is based at Brown University, and the University of Cape Town, specifically the Department of Psychiatry and Mental Health. Our goals really are to provide training and technical assistance around substance use, HIV and mental health care, targeting providers, managers, policymakers, so folks who make things happen for clients on the ground. Consequent upon our funding by PEPFAR, our activities are meant to reach the places most in need in the HIV response, which is why our focus is on the 27 PEPFAR priority districts in South Africa. So this is where it's most problematic. However, we have managed through our activities and through fostering collaborations with neighboring districts to make sure that the reach of our services also benefits areas which are not within the priority districts. And we're very proud of that. So this is a photo taken at the last National Advisory Board in Johannesburg in November last year. So that's just our South African family. This talk really comes at a time when the international portfolio is closing its doors, and I'm hoping to share some of what and how the South African team has managed, with the support of these wonderful people in the photo, to achieve what we've done so far. This is a snapshot of who the ATTC has been over the past 3 years. We have had occasional sessional trainers and technical assistants, folks who've been part of us. Specifically, I want to mention Amy Adams, who was key in developing some of our SBIRT, and I'll speak to what that is in a moment, training. What you see on the screen is a collection of clinicians, scientists, administrators. So it's a really mixed bag of folks who've managed to support our activities. What's also worth speaking to is the work has really been leveraged around the expertise and experience of the folks and organizations represented here. Profs Myers and Sorstal's work in SBIRT in the country has formed the basis of some of the SBIRT work that we do. The Postgraduate Diploma of Addictions Care, currently headed by Fergus Ashburner, alongside Shahima Ali, has really had key sort of involvement in curriculum development. And with their expertise in teaching and student supervision, we've been able to leverage that, and working with folks like Rohana Carter, who's with ICU-DDR International, and with ISAP as well, to really leverage their expertise in our technical assistance work. And we've been lucky to work with Tara Khani from SAMRC, who was a senior scientist there, and her expertise in providing training for adolescent screening and interventions has been really wonderful. More recently, we've welcomed Nurain Tasika, who's an experienced sort of manager of addictions. And this is the US-based team without whom we wouldn't be able to do half of what we do. So Mariah, Caroline, and Sarah. So our objectives as ATTC has really been to help organizations to integrate, and I think that's the key word, is to integrate. So we're not looking at creating additional silos or furthering the concept of silos. Substance use, mental health, and HIV across specifically client-centered settings. I've added that with a view to system strengthening collaboration. Our funding is focused on training and technical assistance, but through collaborations, which I've highlighted lower down in the slides, our mandate really is to support system strengthening by being situated within the organizations whose role it is to provide that specific system strengthening assistance. So through our activities, we've developed or adapted and delivered training and TA to frontline providers for integrated HIV, substance use, and mental health care, with a focus on task sharing, which I think Roger alluded to when he introduced me, which is my pet. I think what's important to mention here is that our activities have been largely above site, so we don't work at the client level. However, we work to capacitate the providers who work with the client. All of this really to strengthen the collaborative networks and disseminate evidence-based approaches in the support of reaching the 90-90-90 targets. By way of reminder, that means 90% of folks should be tested for HIV, 90% of those who test positive should be on antiretrovirals, and 90% of those should be virally suppressed. And with the surge programming in South Africa, that's been increased the targeting to 95, 95, 95. And so we do this really by leveraging the National Advisory Board, who've been with us from the start so reliably as a resource, and by partnering with existing stakeholders. So we're not there to reinvent the wheel. We're aware that there are folks who have great expertise in achieving some of what we want to do. What we hope to do or hoped to do in the 3 years was really to be a conduit to foster and facilitate that sort of collaboration across government, policymakers, service providers, really to help push towards meeting those 90 targets. So the protea is South Africa's national flowers, and what's interesting is that in local tradition, it's actually considered to represent change and hope. And nothing could speak more closely to really the journey of the ATTC over the past 3 years. Don't get emotional, Goodman. And of the country as a whole. So the country is really, the cauldron of change and hope. So in sort of trying to decide how to inform you all about the processes the ATTC has undergone to develop and deliver the interventions we have. Initially, I had this set out as a process, but as I was trying to figure out how to animate and how to put it together, I realized actually it's not a linear process. It's more iterative with jumps between various stages. Having said which, at the outset, we did circulate a needs assessment to collaborators, many of whom ended up being recipients of our TAO training or facilitated the reach of those interventions. And also then managed to bring the National Advisory Board on board to say, how do we best, in the context of what has been suggested by the needs assessment, address these? And so we've done, we've followed up on the needs assessment by engaging with governmental and non-governmental stakeholders, learning from existing ATTCs. The ATTC network is really a wealth of knowledge, expertise, and experience, a responsive network, and I was about to say we'll miss that, but I've remembered we're actually going to keep in touch. So we're not going to miss that because we're still there. So we managed to learn from the existing ATTC success stories, and we are most grateful to Vietnam HIV ATTC for the exposure that they allowed us at the outset. And we then, access or develop and review training resources and technical assistance resources, and then provide those as required. And as has been necessitated rather by COVID now, I think we're all very much aware, I'm talking to you through a silver screen, of how we've had to modify how we interact and how we train and how we deliver our interventions. Anyone who's worked in the context similar to South Africa will know that these are not new challenges. In South Africa, there are times when you can't do a training using electricity because there's no power due to load shedding or other challenges. Connectivity might not work, so you might not be able to play a video which you need to play in a training. You might realize that when you're actually accessing a specific card of trainee, that they're not as responsive to a slideshow, perhaps as they might be to a workbook. So there's had to be some dexterity and flexibility and modification of not just the platform, but the means of delivering those trainings. And the focus has really been on both pre and in-service training, and that'll be reflected when we start to speak about some of the cadres who've actually accessed some of our trainings. And for me, my absolute pet about the whole process is about maintaining and establishing and maintaining collaboration. We know we're stronger together, we get further together, we get better quality together. So ATTC has really been instrumental in fostering, nurturing at first, because there are already existing collaborations, and then fostering additional new ones. And of course, the advisory board has remained key in providing strategic input. And of course, what I'll also speak about as we get to the end is how our monitoring and evaluation sort of is taking shape and how it's going to outlive the ATTC. So as you can see, many of these things in an iterative process don't necessarily follow a linear process. So if we decide that we need to modify a training delivery, we might go to the advisory board and go back to the needs, engage with the collaborator and see what's feasible. Our training and TA cannot be in stone, so it needs to be modified. So all of these engagements are sort of back and forth. This image was taken at our first National Advisory Board in Cape Town in 2018, I lose track at the beginning. In terms of training materials, in response to the technical assistance, apologies, in response to the needs assessment, and in response to our engagements with collaborators and with our advisory board, we were able to identify that these are the main training resources that were most needed in our context. So we focused on basic mental health and practitioner self-care. I'll speak about why the self-care is there in a moment. We focused on screening, brief intervention, and referral to treatment as an intervention that could be leveraged for at all contexts across the service provision platform, and as well as motivational interviewing. What I've highlighted in terms of sources is that you can see that the sources of these materials were from South Africa. So these are resources that were developed in South Africa, and then through the expertise and sort of collaborations with the ATTC network and some of our partners, we were able to make sure that these are in line with the best practice and best evidence and take it forward. So the basic mental health curriculum was based initially on my PhD, which I did in collaboration with Western Cape Department of Health and some very, very smart folks at the Department of Psychiatry and Mental Health. I should specifically thank Prof. Krit Lund, Prof. Dan Stein, and Dr. Peter Milligan, who's now in KZN, for their participation in the development of this manual, as well as Miranda Rulofsson from Western Cape Department of Health. Dr. Tracy Naledi is now one of the deputy deans in the Faculty of Health Sciences, which was also instrumental in that development. So the focus of this training initially was to capacitate community health workers to sensitize them around issues of mental health. As we've developed, it is now more focused on health workers in general with no medical training. So it's not limited to community health workers anymore. In its current form, it is based on a workbook facilitator manual format where the focus is on experiential activity-based learning. The focus on practitioner self-care is a need that came out as we started to cascade this training across the country. Folks were saying, it's fantastic you're teaching folks how to identify people who need further assessment and treatment for mental health. But how do they cope with the engagement with those folks? Because now they have to face their own demons. So we then added a self-care component, which really seeks to protect the provider in the context of providing that support and care in the mental health context. Subsequently, we've linked that with a screening tool. And later on, when I speak about our collaborations, about how we've worked with KZN Center or University of KwaZulu-Natal, no abbreviations this time because I've got an international audience, to develop the community education and detection tool, which is really about using a conversation-style approach to screening and identifying folks who need help. Looking forward to that being published in the near future. In terms of screening, brief intervention, referral to treatment, I mentioned previously that Prof. Sorstal and Myers have expertise in that, and they've done some work in the Western Cape, which continues to be expanded and tested. And so this is work really in partnership with South African Medical Research Council. Folks will also know that SAHMSA and the ATTC network have a vast array of resources which relate to SBIRT. And so we've been able to leverage some of that in expanding and being responsive to the folks that we're providing training to. Our focus in our context has been on the audit, on the DUDIT, and the assist. But we have been able, as I've mentioned before, that we work with folks like Tarakani or Dr. Tarakani, who have expertise in providing training in tools targeting adolescents and kids. So I've highlighted Prof. Rolnick, and if he's watching, Steve, the only reason I've highlighted you is because you're from Cape Town originally. So you no longer live in Cape Town, but it's always nice to have you around to come and just sort of remind us of some of the core principles of MI. So Prof. Rolnick and Miller developed MI some time back, and so Prof. Rolnick remains a partner for the ATTC in modifying and developing our offerings. And this is, of course, in close collaboration with the UCT Postgraduate Diploma of Addictions Care. So the PGDIP has been providing training in MI for a while and continues to support the advancement of these materials. So in terms of training and technical assistance, I love photos. Photos tell a story that words simply can't. On the left of the screen, you'll see a meeting that we held between national government and a representation from all 9 provinces in South Africa to discuss the scale-up of screening, brief intervention, and referral to treatment. So they came with us and said they have a need to standardize training and structuring of the programs. And so that was what we had met, and some resolutions were reached there. COVID and other issues have slowed down the implementation of some of that work, but we're pleased that we'll be able to carry on that collaboration after ATTC ends officially in 2 weeks' time. And I'll talk a bit more about that in a moment. We've also at the top, you'll see an engagement we had with national government to talk about the foundation training for community health workers. So we've had some input there, which is a love of mine. I'm very pleased that we were able to offer our expertise and support for that. And there's Steve Rolnick at the bottom in the middle photo, providing a training to managers from across the Western Cape. And we had some national folks come in as well. So it's really about talking about where does MI, where does SBIRT sit in the greater scheme of system strengthening, and allowing them to then, just think about, in what ways they could make use of that as a resource. I put REPSI there. REPSI has a special place in my heart. The reason that, we provided TA for REPSI, they wanted specifically the non-specialist mental health training in order to make their their work more responsive to mental health challenges. REPSI is the Regional Psychosocial Support Initiative, and they operate in 13 countries across East and Southern Africa. And so they've, in the course of their work, become a leading African psychosocial support organization for technical support and capacity building. So we were very pleased to be able to partner with them in a technical assistance intervention. In terms of training and technical assistance, some of the images that you see here represent some development work and collaboration. So in this particular image, it's one of the sessions where we were working with University of KwaZulu-Natal Center for Rural Health to develop that community detection tool. And at the bottom is a photo that shows a collaboration between Catholic Relief Services, TB HIV Care, University of Cape Town, and a couple of other partners to really just give input and in-depth sort of feedback on the mental health material, which has really come so far since the early days. And it's really just been through collaboration and honest engagement with folks. And we're so excited to see where it's at now. So at the top is just a photo with Catholic Relief Services after they started their funding cycle, receiving training in MI and SBIRT. This bottom photo shows the inevitability of South Africa at the moment, where occasionally we lose some light, and you see people come together. Somebody chose to use their mobile phone to illuminate Fergus so they could see him during the training. So in terms of our training events, you'll see that in year 1 we were able to hold 44 trainings. In year 2 we went up to 47, year 3 down to 27 for obvious reasons. So I think what's worth mentioning is the reason we were able to get off to such a strong start and start with 44 trainings is, again, because of the existing materials that we could leverage, and which I referenced in the earlier pages. In year 2, we were able to keep that momentum going, and much credit to my team, hard work and lots of sleepless nights and travel across the country to effect these interventions, interspersed with technical assistance activities, which aren't necessarily reflected in these numbers. So these numbers specifically speak to the training events. They don't speak to the myriad of other technical assistance activities, which I appreciate and really I'm very grateful for my team for what they were able to give of themselves, because this has really been a grueling 3 years in terms of, because of the dedication and the sort of the demand for what we were providing in terms of assistance. In year 3, you see that we've had fewer events. However, the reach has been fairly similar. And the reason for that, again, is because most of our activities from March onwards had to be online. So the upside of an online activity is that you're able to reach more folks. And so even though we couldn't be with people in person, we were able to still make an impact for providers. In terms of training curricula, again, this really reflects what was available and how the picture changed. So the mental health curriculum was already available and sort of adopted. So it was the one to pick up the quickest in year 1. Whereas the other curricula were still being fine-tuned, even though they were available, so that those picked up in year 2. And in year 3, because the mental health is most face-to-face orientated, we had the least amount of trainings, But what's really good about what's happened in year 3 is we've been forced to say there's actually a need to create an online accessibility for this mental health material. So we're working with our friends at Foundation for Professional Development to really develop that material. We're really excited to see how much further it can reach, how many more folks can be allowed to benefit from that. So again, just the lower numbers in year 3 represent, the impact of COVID. So there couldn't be more face-to-face activities. But again, as I mentioned before, we were able to still meet the training numbers in spite of that. So in terms of total trainings by province, you'll see that the Western Cape is a fairly big chunk. At the outset, while we were still working out our curricula and making sure they were responsive and appropriate, most of the work was happening in the Western Cape. And it's also important to note, I showed earlier a slide with Steve Rolnick where he was kind enough to do a remote lecture for us from Cardiff. So some of the activities which are marked Western Cape are actually national events where folks came down to Cape Town. If you know Cape Town, you'll know why they came down. If you're listening, you've never been to Cape Town, once the borders open, you will come down to Cape Town. So some of those events are marked as Western Cape, but they were actually national events. So the numbers actually represent a wider sort of collection of Cardiff than just Western Cape. So you also see that KZN has quite a huge chunk, and this is really due to the strong collaboration we've had with KwaZulu-Natal Department of Health. And and they were able to identify and remain so their system needs, and were able to direct us in terms of where they wanted us. I'm also slightly biased because I'm from KwaZulu-Natal, so I'm pleased to see that we've been able to have such an impact in the province. Gauteng Health we've managed to impact through the US government-funded partners, and we're increasingly now engaging with the Provincial Department of Health, and there'll be some exciting progress in terms of that collaboration in the period after the ATTC. I know it sounds weird, I keep talking about the period after the ATTC, but I think it'll make sense as we proceed. So in terms of the reach of our trainings, these are the folks that we were able to reach. Unsurprisingly, in terms of social workers and counselors and nurses, we spoke about how the SBIRT and the MI were the ones were the curricula most accessed, and these counselors are, at the forefront of interaction with clients in the clinic and primary healthcare space. So they were the ones who were most eager to gain competence in motivational interviewing, gain competence in how to identify, briefly intervene, and refer as appropriate. So you'll see that we also were able to reach lay workers, social auxiliary workers to a lower degree. If you look down, you'll see that there are some medical practitioners and psychiatrists. Some of our work was focused on sort of detox training and other sort of cold face interventions, which were more appropriate for medical practitioners. And I specifically want to thank again here Dr. Peter Milligan, who was a great help to us in the province in KwaZulu-Natal in reaching those psychiatrists and those medical practitioners. People like us, so the trainee satisfaction seems to have gone pretty well. So I think you can see all the numbers look great. So in year 1 and 2, we seem to have had general good satisfaction. People enjoyed good quality, they enjoyed the information they received. They felt it was relevant, it enhanced their skills in the topic area. They felt it was relevant to their career, so we weren't wasting their time, but they could have been walking a dog. And many felt that they could use this information and apply it in their work, and felt that the skills learned would certainly benefit their clients. This is just additional satisfaction data collected from the first 158 trainees who received SBIRT training. So I think that speaks for itself. So we're pleased that folks were receptive of the work that we were providing or that we were undertaking with them. And we're also pleased that they felt that it was going to impact on the quality of the service they were able to. That's really the one to deliver in the community. We recently conducted a survey of trainees, so this is an ongoing survey. So we constantly are listening to how folks are engaging with clients and with the materials that that we're providing for them. So I think what's really great to see here is that about 40% were able to say that they are now screening more than they were before, which is great. I think what's also good to reflect on here is that we asked all the trainees, so at this particular point, this is not stratified according to SBIRT, mental health, or MI. And so that might be what's reflected in those who don't screen as much, who say their screening is unchanged or they screen less often. Also, in the context of COVID, much of the workforce was redirected to the COVID response. And under the leadership of our government, those folks were put where they were really needed in tracking and tracing, and they've really been a great asset in bringing COVID under control in our country, and I applaud them. But I think as a result of that, some of the screening work for substance use may have fallen to the wayside. And that's another topic for another day. So in terms of this survey, some of the quotes we received from folks who partook in the survey, we asked them, can you share an example, a story of how the training that you've received from the ATTC has affected your work? One said that it's made them assess their clients more holistically, and made our screening effective and efficient in terms of time and data collection. When you know what you're doing, you do it more efficiently and better. So that's great. I'm more aware and confident of what type of questions to ask. The training has done miracles and has affected so many clients. We're thrilled to hear that, to overcome their struggles. And one said the adherence to treatment has improved since I've learned to screen almost all my clients. I felt ready and equipped to manage substance use clients. Additional response to a question that said, can you share an example of the story of how your training you received from ATTC has helped the clients that you serve? Many people identify on the spot if they need help. So it's that capacitation of the client through the skills they learn in MI, the skills they learn in the brief intervention approaches that we've trained them in. And they've come back and say that their organization has helped them a lot. And then one says that my clients have been able to make more informed decisions, and some have gained insight with regards to the substance use problems and issues. So this is really great. It's good to see that there's been an impact on clients as well. I'm going to give it 2 more seconds in case someone is frantically reading all the words. So in terms of what's going to happen now, ATTC funding, international ATTC funding comes to an end at the end of September. But what are we leaving behind? We're pleased to leave behind a strong motivational interviewing training curriculum. And through our collaborations and friendships in South Africa and with motivational interviewing trainers around the world, we've been part of the initiation of Motivational Interviewing South Africa. So we look forward to seeing that body grow with the support of the International Motivational Interviewing Training Organization, MINT, or group MINT. We've also been, and I'm super proud of this, of course, because it's KZN again, and I'm totally biased, for our work that we contributed in terms of an MI-orientated staff mentorship framework. So really excited to see that come through during COVID. Some really fast and considered work took place to get that together. And we're really excited as well to be moving forward with an Africa MI Forum. Super excited. So we're bringing in practitioners and trainers in MI across the continent to talk about issues which are really pertinent to Africa as a continent, and about how do we take forward the principles of MI and capacitate folks to deliver and receive training and to effect some of those learnings in service delivery in their context. Super excited. In terms of screening, brief intervention, and referral to treatment, the ATTC leaves behind a provider-level training curriculum, as well as a trainer-level training curriculum. Our team thus far has been providing master training, and some of the work that will continue in the entity that will survive the ATTC will be around providing continued cascade training around SBIRT. And some of that work will be sort of captured in when I speak about the Brown Alcohol Research Collaboration in HIV/AIDS, or ARCH, as well as the NIAAA grant, which sort of form part of the achievements which relate to how we've managed to successfully deliver SBIRT. I mentioned earlier the SBIRT Draft National Policy Framework, which I may have called the Scale-Up Plan. So that's part of the legacy of the ATTC, and of course, not taking all the credit here. We're saying part of the collaborative that put together the ideas around the policy framework. And we remain committed in the time post ATTC in working with national government and the provinces to really finalize that and operationalize the cascade SBIRT training. And so we've also sort of assisted or participated with the SA HIV Clinician Society in developing the harm reduction guidelines, which I believe were published on World AIDS Day last year, if I may be mistaken. In terms of mental health, really come leaps and bounds. I'm very happy to see where we are now. We are able to provide training manuals for provider level, trainer level, and master trainer level. The images that you see on the screen are the covers of the two manuals for the providers and the trainers. And these are freely available on the ATTC website. So if you go to our website, the URL will be at the end of my presentation. You can be able to see some of these resources, and some of these will be here. ATTC is positioning itself to be ready to provide master training. So if an organization wants to provide this training in South Africa, we're here to support that through training and supervision and mentoring after that. We're working with Foundation for Professional Development to develop the online version of the training, which I'm really looking forward to. It's going to allow us to have a wider reach across the continent as well, and allow for self-paced learning, which is accredited. So folks will be able to walk away and know that they've achieved a new level of knowledge and hopefully acquired new and assisting folks with mental health challenges. So, and again, I mentioned before that we collaborated with our University of KwaZulu-Natal partners at the Center for Rural Health to develop the community education and detection tool. In addition to that, we've developed a series of videos over the past 3 years, which enable our sort of trainees to see. This is what a motivational approach looks like. This is a negative emotion, sort of style of assisting a patient. This is a constructive MI focused style. And so these videos are all again freely available on our YouTube site, which you can access through the URL that you see on the screen there. I think what's also good to mention is you'll see here that in collaboration with ISAP South Africa, we were able to put together a webinar discussing COVID-19, the treatment of substance use disorders. It's been a hot topic in South Africa related to the alcohol and tobacco ban. So this was one of the first webinars that the ATTC was able to sort of bring to the fore. It's been a hot topic, so you can be able to access some of these on our website. So our story is really about talking about the experience of a substance user. Some of these folks have been able to bring their lives together and are now care providers. And so these stories are really great as a reflection and sort of an insight into the journey that they've had to walk. And it helps us to think about the approaches that we're using to assist them. It helps us to think about what really is most needful from their side for them to make the next step, which really is the core principle of MI, allowing people to realize what they need to do and mobilize that internal motivation. The last block on the right was Prof. Rolnik when he was down in Cape Town to do a lecture for us at the Department of Psychiatry and Mental Health on MI in clinical contexts. In terms of networking, as you can see, we're talking on the ISAP platform. So we have relationships with International Society of Substance Use Professionals, both globally. Hello, Jeff. Hello, everyone. I hope you're watching. And as Roger mentioned earlier, I'm part of the South African the steering committee for the South African chapter, and we're growing the network. So if you're listening and you are professional in the substance treatment space, please hit us up and let's talk about how do we grow the network of substance use professionals. We're doing some work to really bring traditional health practitioners into the fold. We have to do this together. There's aspects of management which the Western model is skipping out on. So this is a key element of the work that we're doing. And we also sort of work side by side with the International Consortium of Universities for Drug Demand Reduction. Rihanna, I hope you're watching as well. So in the same breath here, we working on the international platform with the regional group as well as with the ICDDR South Africa. Lamise, I hope you're watching. So in terms of additional legacy materials, through the course of COVID, but also as a result of some of the listenings that we've been doing for our collaborators who've been telling us what they need. Self-care has just been, self-help, self-care has been a consistent theme. And so we just developed these materials to help folks think about some ways in which they could deal with some of those stresses. Not the only ways, it's just some options. These are some more coping with distress. So some of these are drawn from some of the mental health material. I think I spoke earlier and said, the mental health is very much focused on practitioner self-care. What about the provider? So some of these are drawn from that. And that's, when you talk about this, the spirit of motivational interviewing, what we've done is we've adapted that into a less jargon-orientated intervention where we're talking about how to be a guide on the side. And that's what, so some of this is pulled from. And so in how we train folks in the mental health offering, we talk about specific strategies for self-help, such as reflection, stopping, catching your breath. And so now these are available as one pages on our website, which you can see at the top of the page there. And if you're like interested in these and you don't have enough time to write them down and take a screenshot, again, the URL will be at the end of my presentation. So this is the exciting bit of our legacy. Through Brown University, we've been able to secure the Brown Alcohol Research Collaborative in HIV/AIDS Center grant, the ARCH grant. The initial funding for this was achieved in 2019. And we're really thankful to TB HIV Care and Sanka National for assisting us in the initial design and piloting of the materials that we'll be using for the grant, which I'll mention on the next slide. So the real goal of this grant, of this initial funding, was to develop the research scaffolding for the larger grant, and for the M&E plan as a whole for the Addiction Technology Transfer Center. So through this process, we were able to develop an automated culture relevant screening system to foster widespread substance use screening and real-time data tracking for pre-screening tools for alcohol and drug use in these HIV contexts. And we then developed a comprehensive M&E plan to support data collection at organizational, patient, and provider level. And so we're looking forward to sharing with you how this evolves as we move forward with this, the NIAAA grant, the National Institute on Alcohol Abuse and Alcoholism grant, which is targeted evaluating the implementation of the evidence-based strategies for SBIRT. So it's looking at, does the cascade SBIRT model actually impact on client care? So this was awarded to us, we're very grateful, in July 2020 for 5 years, and we also have ethical approval now, so we can move ahead with the project. So the purpose of this project is to extend the work of the ATTC by evaluating the effectiveness of our training cascade model. The target over the 3 to 5 years is to train 900 workers and lay counselors who are embedded within these HIV treatment organizations. I mentioned in the previous slide that our collaborators on this project are TB HIV Care, KwaZulu-Natal Department of Health, and Sanka National, and those same three organizations who are partners in implementing this NIAAA grant. Oh, it's right there as well. I forgot I put it there as well. So the goals of this project specifically are to provide the SBIRT training sessions to about 30 master trainers, who will in turn then go and train the 900 health workers and lay counselors who are embedded within the HIV treatment organizations over the course of the next 3 to 5 years. So really it's about advancing the science of implementation by carefully monitoring the train-the-trainer cascade approach. Remember I said earlier, while our focus has not necessarily been directly system strengthening, our interventions sit within a system improvement strategy within the collaborator that we're working with. So we want to make sure that it's being impactful, and so this is what this is about. We also aim to then codify and evaluate the outcome of the national SBIRT training initiative at multiple levels. So at trainer level, at provider level, and at patient level. So does the SBIRT actually reach the appropriate and eligible patients and effect the kind of support that's required for them to get well? So these are so some of the collaborators that we've worked with who I consider our friends over the past 3 years. I'm sure that I've missed some, and so they're going to be really mad at me. I'm going to get texts after this talk. But this is, largely the organizations that you've worked with, and we're grateful for your friendship and your partnership. And we're looking forward to finding ways to sustain much of the work that we've already started with you. What have we learned? We've learned that things that enable the work that we sought to undertake are a needs assessment. You have to know what you're addressing. So the needs assessment was a key part of the success of the work that we've done. Early buy-in through engagement with the National Advisory Board, meaningful engagement, so not just superfluous for the sake of ticking a box, and being responsive to the needs of the communities within which we're working, being responsive to the input of our National Advisory Board and other experts. Flexibility, I spoke about how we've had to change some of our training techniques, and I think COVID was one of those big tests. We really had to move along and come quickly through with adapted materials to continue to provide that support. The challenges we faced, our funding was to cover 27 districts, and our team is pretty small, and so that resulted in many sleepless nights and at least, I guess, some airline miles for my team. And so the system wasn't always as prepared as it might be to receive and place the intervention. So that was certainly a challenge that we've had to face. But I think our collaborators have been up to the task. So you're seeing collaborators like KwaZulu-Natal Department of Health really mobilizing, district response structures, and some of the work that the province has done with organizations like the MINT program and University of KwaZulu-Natal Center for Rural Health have really been sort of essential in that collaborative effort to strengthen and reinforce the system so that these interventions have a place to sit in and that they're then effective. And of course, the overlapping roles in the context of South Africa of social development and health when it comes to behavioral interventions has been the challenge is the right word, because it's you find the synergies and there's ways to then make sure that we are able to be impactful and provide good assistance. I'm going to go back to that last bullet point. So I think the other challenge that we had was really about linking HIV outcomes to training and technical assistance interventions. Because we're above site, it's difficult sometimes to relate some of our work to the actual outcomes for clients on the ground. The final enabler that I want to just circle back to is the just immense and unconditional support we've had from in and out of country funders. So the support has been fantastic. So I want to thank you, Laurie Crom, thank you to Umberto and Chris and the other folks at SAHMSA, and to thank Beverly Cummings for the work she has done to support us regionally and in South Africa. And of course, there are a bunch of other people that are also going to be mad at me for not mentioning them, but I thought that those were really important to mention. So what's going to happen next? The US Department of State has recognized the value of the TTC network, International ATTC network, and through the Colombo Advisory Program is funding some of these centers to become international technology transfer centers. Now, the focus of the International Technology Transfer Center, which will kick in on the 1st of October after the ATTC closes its doors on the 30th of September, is really on drug demand reduction, provision of training, development of curricula, and again, fostering and nurturing those national, regional, and continental collaborations. And so I think what you'll see that's missing there explicitly is mental health. But through our affiliation with the TTC network, so I think if in case that's a little bit confusing, before I spoke about the ATTC network, the exciting bits about the TTC network, it's grown so much. So there's now a mental health technology transfer center and other elements to the network. And so together they call the technology transfer network. So through those networks and through those linkages, we'll be able to continue to provide that TA and assistance in mental health and support some of those programs. And we're also thrilled to continue to be affiliated now more officially with ICUDDR and with ISUP. And so we're grateful to US Department of State and the Colombo Drug Advisory Program, and look forward to the new ITTC network, international network, and to seeing what it can achieve on the continent and in the country. Of interest, when Roger introduced me, he mentioned the Drug Demand Reduction in Africa conference. It started yesterday. We have a session every 4 weeks or so. Please go check it out if you haven't registered. Amazing topics. My topic that I'll be moderating on the 4th of November will be that talking to the role of traditional health practitioners and policymakers in drug demand reduction on the continent. So I think that's going to be interesting. In South Africa and in Africa, we are working on the addiction conference. Please go read a bit more about that as well if you have a moment. So we're really looking at igniting a movement for change. We want to talk about what do we need to do to take things to the next level, to make sure that folks in the treatment space are actually taking it upon themselves to enact the change that needs to happen for the best practice treatment of folks to take place. So in closing, I want to say thank you wholeheartedly to PEPFAR and SAHMSA for the exposure, for the experience, for the wins, for the support, and for what you've managed to provide South Africa with through the ATTC. These resources will continue to be an absolute gem and sort of a value add for our context for some time to come. As I've mentioned, the products will continue to be maintained through the ITTC and through the University of Cape Town's Department of Psychiatry and Mental Health. There's the URLs there in case you want to visit them. And we have every intention of continuing to maintain those local and international collaborations. Thank you so much for your time. Please reach out if you want to discuss some stuff. Roger, I'm in your hands.
Thank you very much, Dr. Sibeko, for a very informative and eye-opening presentation. It's always great to see the amount of good work that is happening in our country and across our continent. And thank you for equipping us with all those fantastic resources that the ATTC has left with us. We look forward to our ongoing collaboration as ISIP and ITTC from October onwards, and we are very, very proud as ISIP South Africa to be a collaborator with ITTC. So we want to thank you very, very much for joining us on this session. Please feel free, as Dr. Goodman has said, if there are any questions or anything that you'd like clarity on, please email him directly. His email address is right there. And we look forward to welcoming you as attendees for our Virtual Africa Conference. Our next session is on the 22nd of September, which is next week, Tuesday. Please log on to www.isip.net and look at the events section for that. Registrations are still open. Thank you very, very much once again for your presentation, Dr. Sibeko, and we look forward to hearing more from you as ITTC takes over. Thank you.
Thank you.